also reporting to a tag time of 20 minutes. We all have our pieces to share with you to tell the story of the improvements for this RPIW. So here's our fabulous team. We are called Crazy Eights, and not because we are crazy, but rather this great team of 8 people are crazy for quality improvement. So they will share a story again with all the wonderful improvements that they have made. So I'd like to introduce to you Brenda Summerfeld, Lynn Oliver, Patty Bergen, Joanne Heppelthwaite, Madeline Matisse, Nell Nickel, Lori Friesen, and Dr. Ositsky, or Stan. Sharon Griffin, our sub-team lead, and I've introduced myself already. So our goal in our project form really was to decrease the lead time for patients by improving the discharge planning process. And that point was from ACAP being contacted right through to when the discharge plan was complete. So the focus was on level 5 and 6, and on what we were trying to achieve is to decrease that chaos and the surprise of the discharge happening, and that chaos around the planning that has to take place, as well as improve by streamlining the processes. So the important thing that we were able to do some improvement in is the flow of information and then the flow of providers. So our story began with our value stream map. And this was in preparation for this week. There are 3 real main areas to highlight, and that is when ACAP determined the ELOS, so the expected length of stay, the referral meeting that took place, both of those 2 batching was happening, and the home care referral piece, the end over here, where that too created some lengthy time that we focused on improving. So the lead time for the whole process from ACAP to the discharge planning process to be completed for a home care referral was over 4 hours. So we did a number of timed observations. That one piece of the home care referral that I had outlined, it was on that end of the value stream, that took around 81 minutes. And again, this just shows the wows and the waits. And here, there's the pieces of time. So the patient interview is the number 1, number 2 is the consult that takes place, number 3 is the document preparation, and then number 4 was that home care referral piece. So just the post or the pre-Kaizen target sheet with some of the data or some of the measures that we were following. The first one really around the distance walking and the park travel, that was something that was a very significant change that you'll hear about, as well as that included the number of steps, the number of times there was double entry, and then, of course, the batching of the expected length of stay data and the referral meeting. So I'll hand it over to our great team to share the improvements that they made in their sub-teams.
Hi, my name is Brenda, and I'm an RN, and I have worked with the ACAP team and also as a nursing supervisor. So I had the opportunity to be part of the team that looked at several areas within the PCC ACAP team. PCC is a patient care coordinator, and ACAP is our acute care access program, which is made up of a 2-person team. We developed 5 pieces of standard work, which hopefully will result in increased efficiencies and improved patient access to services and improved communication between our healthcare providers. So I'm going to talk about one of those pieces of standard work created. So prior to the RPIW, the ACAP team would do their patient assessments and batch them throughout the day. And then assign them to PCCs the following morning at the PCC meeting. PCCs would then start their day with sometimes as many as 6 new patient assignments each morning, along with their current caseload, which is already very heavy. So the problem identified was a delay in the patient sometimes meeting their assigned PCC, and this delay could be hours and sometimes days in certain cases. This results in a delay of early planning with the patient and their families and ineffective communication between all of our healthcare providers. So we established some standard work, which will have the ACAP team assign the patient assignments to the appropriate PCC as they are done throughout the day. The PCC will then make a point to go and introduce themselves to their patient and identify themselves as the patient's PCC on the PSEG board on each ward and also in the patient's chart. Some of the improvements we hope to see with this will be that with the patient assessments done and assignments given out as they are done, as they happen, this obviously will decrease our batching of work and also shorten the time spent in the morning meeting. PCCs will have the opportunity to prioritize their workload and will have that important early contact with their patients. Patients and families will also have earlier access to their patient care coordinator and be involved early on in their plan of care and plan for discharge. And also hopefully will be improving communication between nursing and all the other healthcare providers as they will know whether or not their patient has a PCC assigned on the day of the patient being admitted. Thanks.
My name's Lynn. I work in the ACAP department. And the next problem we identified in this area was inconsistency in the home care referral process and also the extreme amount of time it took for the patient care coordinators to actually make that home care referral. So prior to the improvements, the total time we were looking at for a home care referral was close to 30 minutes, 29 minutes at a day. And during that time, you can see the patient care coordinator was having many interactions with the nurse on the floor as well as with the ward clerk, discharge plans, faxing, and most significant was the 20 minutes for the Procura, which is the electronic home care charting system. So what we did was we standardized the process and simplified it and eliminated the entry into the Procura. And we also delegated the faxing to the ward clerk on the floor. So now resulting in a more consistent home care referral process. The ward clerk will now look after the faxing. The PCC sees the patient, creates a discharge plan, and the RN looks after the nursing piece of the care plan, and the Procure is eliminated. So we gained about 17 minutes and 23 seconds per referral, which is significant because they have several referrals in a day. So this was a piece of standard work, and the PCC or ACAP completes the referral form, the discharge package. They then put it on the chart, phone home care, and the package is faxed by the ward clerk. And this is the form that is replacing the Procura. It's under revision, but at the present time, this is the standard form that we've always used. Will continue to use.
Good afternoon. My name is Patty Bergen. I am a patient care coordinator for Level 5. Pre-RPIW, our PCC offices for Levels 5 and 6 were located in the trailers out front of the hospital between the main doors and the Herb Bassett home. The distance traveled from the trailers to Level 6 and back was 1,782 feet. Many people have identified that this distance takes up too much valuable time in each working day. With the idea of having PCC offices located on Levels 5 and 6, this would be significant for families, patients, and other disciplines to access PCCs more readily. On any given day, PCCs traveled frequently back and forth. We can show this diagram. From Levels 5 and 6 to the trailers for the purpose of computer use, to access resources, and at times patient and family meetings.
With home care. Our target was to reduce the 1,782 feet that the PCC reduce travel from the trailer to the floor. We moved the PCC offices to level 5 and level 6. This has reduced the number of steps traveled from the trailer to the floor to 0. So you can see from the spaghetti diagram, we no longer have to go back and forth to the trailer, but the office is right there, the nursing station is very close, and then it's also close to the patient rooms. This is a diagram of level 5, and it's circled where the PCC office is, right across from the nursing station. And this is level 6. This is where the PCC office will be located. It's just kind of around the corner from the nursing station. And this is where, this is the office on level 5. At the present moment, the PCC office will be shared by other disciplines. We have developed standard work for the PCC interdisciplinary office use. In order to help communication, all team members are to log off the computer when leaving. There will also be a sign placed on the door when there's a meeting in progress. Another piece of standard work we developed was around PCC resources. All PCCs will have a standard set of resources in the PCC interdisciplinary room, and the PCC will ensure that the resources are kept up to date.
Hi, I'm Stan Olsinski. I found a position here at Prince Albert, and I'm talking to you about time to discharge. So in the past, I've been here for 29 years. We seem to have more face time with other healthcare providers, and as a physician, we would often communicate how long we would think the patient would need to stay in hospital. Sometime over the last 29 years, that stopped because we've been meeting with each other so much. So now ACAP has been developed, and so then they were repeating some of the work processes. So this is turning back the clock. So us as physicians, when we do our assessment, we'll actually then tell the nursing supervisor, nurse in charge, I think the patient's going to stay in X number of days. That will be recorded upon the doctor's order as by the physician or the nursing supervisor, ER charge nurse. So we developed some standard work towards that, and this is just showing the standard work. So it would be standard work for the physician as well as either the nursing supervisor or the ER charge nurse. There's also going to be a training that's going to be going on. It's just basically to inform everybody that this is happening. So it'll be happening on the nursing side as well as the physician side. The next part that we went to is discharge planning and for home care services. Again, in hospital, in the past, people would actually stay in hospital longer because there were no services out there. Now they can go home earlier. So as you heard earlier in the past, the PCC would have to go back to their office, which is many feet away, and fill out a form on computer. Now they're just going to fill out this form here, right on the ward. If you flip the form over, so that's the old sheet. It was a two-sided sheet, fairly cumbersome. And if you show the new one, this is the new proposed one, which will hopefully be implemented soon. It will be much simpler and easier to fill out by the PCC as well as the physician as required.
Another piece we worked on was communication, as we've heard already has been an issue, as well as keeping accurate track, or as accurate as you can, to do with the target discharge date. So some very smart nurses on the levels had come up with their own form. We called a hit list. So this is what it looked like, pretty much the same for level 4, 5, and 6. It was basically a communication tool between nursing staff and physicians where they would come in and put what they needed for the day. So what we have done is added to this list where now anybody in the interdisciplinary team can use it. We added a space for the physicians to put their requests and a space for the disciplinary teams to use it, as well as a target discharge date. So in this case, if the target discharge date wasn't noticed on the original admission orders, that would be one of the things that would be communicated on that sheet, and it would then be transferred from that sheet to the PSEC board or the patient status at a glance board, which now is kind of difficult to keep up to date with people because they're never sure what the target discharge date is. So if it changes or if it's not there, it'll be communicated on that sheet, as well as everybody kind of being able to, at a quick glance, be able to keep track of where they're at with their discharge and hopefully
prevent some of those accidental quick discharges, which obviously we're going to get a lot of.
Hello, I'm Mel Keppel, and I am patient. In 5S, the resource area in the trailer, we reorganized the 3 shelf areas and 4 bulletin boards, which were quite cluttered. We disposed of out-of-date material. We organized the bulletin boards in categories. We disposed of 1 shelving unit and relocated the filing cabinet to better free the corridor. And specific resource material was given to designated PCAs on levels 5 and 6.
Hi, my name is Lori Friesen. I'm the Director of Pharmacy. I was part of the team at 5S, the Resource and Supply area in the PCCU. So a summary of what we did over the 2.5 days was we increased our 5S evaluation by 25%. We gained 3,788 square feet of space. We eliminated 2,394 pieces of waste, either by discarding it or transferring it to a more appropriate place. To increase quality and safety, we discarded old and outdated products. And as all the items were moved for paper or free brochures and pamphlets, we did not save any money, but our biggest gain was in space recovery. We also developed some standard work to ensure that the area stays the way it looks now, or preferably maybe even better. So they're going to do 5S audits weekly, and the standard work's been set up for that, as well as the standard work's been set up for ordering of supplies.
Good afternoon, everybody. My name is Sharon Griffin, and I've been the sub-team lead for the Crazy 8 team, and I'll just take over and let you know what happened once we started implementing some of the improvements that were identified. First of all, the home care referral process, which if you remember from the pre-workshop, that took 81 point some minutes. We're able to reduce that down to 24.25 minutes. So that's a dramatic improvement, allowing them to work to their attack time of 38 minutes, which prior they could not achieve. Gives them more face time with their patients. And also in the percent load chart, the attack time being 38 minutes, we were able to eliminate altogether the 4th. Our post-improvement value stream mapping of the process involving the ACAP contact to the discharge plan being complete by either ACAP or the PCC. If you remember before, the value added and the non-value added percentages of 90-some and 7-some really has not changed significantly from the provider's perspective. But what you can't see in this is that we were really effective with creation of standard work, in that our ACAP team now and PCCs have very clear roles and responsibilities, and ACAP is able to help them load level their work, so and perhaps avoid some consults to PCCs. Our target progress report and results sheet, we were able to make significant improvements in things like walking distance, parts traveled by 100%. We were able to decrease our lead time and defects effectively. And our home care referral process, we hope we will make significant improvements by eliminating the double documentation. So even though we were doing it twice before in different formats, we were doing it wrong at least a significant portion of time. Our newspaper items that we identified, we were able to complete a lot of them, 100% for handoff. We do have a few items that we need to carry over. There were a few things identified as well that we considered fail forward fast because they're too big to tackle, such as the care plan, the trigger tool for estimated length of stay. There's a few things just involving forms that need to be approved through health records and practitioner advisor committee. And in summary, our workshop we found was very effective at standardizing the home care referral process, and we will be auditing that, and we hope that we will improve their workload a lot. It was great for us to have the physician involvement because it's really helpful for physicians to engage physicians. And the relocation of the PCCs we think is an awesome accomplishment, and there's plans for level 4. And our team communication was great amongst ourselves as with the staff involved. And in conclusion, I would really like to give a shout out to a few people. Number one, the Crazy 18, because they were awesome. You've met them all. Val Middlebrook for helping us with all of our clerical work. Brenda Andre, I told her I'd give her a special shout out because initially calling for help and supplies, she's the only one that got back to me right away. The staff on levels 4, 5, and 6 in ER, because we were in there consistently disrupting their work therapies, for giving us some feedback and allowing us some time to discuss some issues with them. Maintenance staff, environmental services, Brad Pearson also for getting some printing done very quickly for us and tablets made. ACAP and PCC staff, of course, because that's the unit that we were working very closely with. Our process owner, Alana Ross, our sponsor, Carol Gregory, Linda Sims in home care for helping us sort out the home care piece. And I also want to give a shout out to our nursing supervisors, because while Brenda and I have been tied up in this, they've been keeping the place afloat here for us. So thank you. And in conclusion, because we are called the Crazy Eights, I think it's appropriate that I share with you, I've learned this from my children, that sometimes when there are no words to explain something, you just have to say, that's crazy. Crazy, but we